The American Brain Tumor Association is pleased to welcome you back to our webinar series. Our webinar today will discuss Understanding Diffuse Intrinsic Pontine Glioma, DIPG, and New Treatment Approaches. My name is Nicole Wilmarth, Chief Science Officer here at the American Brain Tumor Association. I'm delighted to introduce our speaker today, Dr. Mark Kieran. Dr. Kieran is Clinical Director of the Brain Tumor Center at Dana-Farber in the Boston Children's Cancer and Blood Disorders Center. Dr. Kieran received his PhD from the University of Alberta, Edmonton, Canada, and his MD from the University of Calgary. He completed postgraduate training in molecular biology at the Pasteur Institute in Paris, his residency at McGill University in Montreal, and his fellowship training at Dana-Farber in the Boston Children's Cancer and Blood Disorders Center. In addition to treating patients with brain tumors, Dr. Kieran's research focuses on developing novel agents to treat recurrent tumors. Thank you for joining us, Dr. Kieran. You may now begin your presentation.
Yeah.
Yes, and we can see your slides. Thank you.
Okay, so it's okay if I get started again? Okay, so I apologize for some of the technical issues. And since some of the original stuff wasn't perhaps heard well over the audio system, I'm just going to repeat it, kind of start almost from scratch. So again, the goal of today's presentation is really going to be to talk somewhat about the standard approaches that we've used for DIPG over the last many years and why they haven't worked, and how that's led us to the embarkment of some new approaches, in particular the biopsy of these tumors to better understand them, on the recognition that if we understand them, we have a chance of actually developing effective therapies. So this is a picture of the classic brain that you can see here on the right-hand side of the screen, and in the middle is the brainstem, the critical part that's found in most higher organisms or vertebrates and is critical for the basic functions of the brain. And the brainstem is broken into three major areas, what's called the midbrain, the pons, which we're going to focus on, and the medulla, but all three of them kind of share very similar functions. What's important, though, is that tumors arising in the pons are completely different in terms of both their biology and their outcome from tumors that arise in the midbrain and the medulla, and because they're often confused, sometimes accounts for the misdiagnosis of patients. Now, as I've said, this is a kind of critical area of the brain. It has three major functions. The first thing is that it connects the upper part of your brain where, for example, you decide to move an arm or a leg down to the actual arm or leg so that they get that message. So it's kind of the conduit for all of the electrical impulses that are decided in the upper part of the brain. It's also the part of the brain that controls the movement, the 12 cranial nerves that regulate the movement of the head, the eyes, the mouth, those kinds of things, which means tumors in this area can affect those. And it controls the basic functions of life, such as breathing all the time so that when you're sound asleep, you don't have to remember to keep breathing. It happens automatically. Your heart beating, your blood pressure, and your ability to be awake or conscious of what's going on around you. So again, very critical basic function. For patients with DIPG, basically have a tumor in the very middle of that part of the brainstem called the pons. And we know this based on a variety of both clinical symptoms and MRI scans, and that's how we make the diagnosis. So not surprisingly, when we look at the symptoms of DIPG, they're typically present rapidly. So most patients, it's not a question of, well, he's always been clumsy or he's been having this problem for years. Most patients will say, or most parents will say, yeah, actually, a week ago Wednesday, he suddenly started crossing his eyes for the first time. They can almost remember the day it happened. Tends to be relatively rapid. It progresses relatively quickly. And again, the symptoms are exactly what one would expect for this part of the brain. So for example, the cranial nerves don't work properly, so the eyes don't move properly, the mouth doesn't move properly, those kinds of things. You can obviously have some problems with the arms or leg because of interference of the signal going down. And finally, because the cerebellum, the part of the brain that controls coordination, is just behind this area, means that sometimes your balance isn't normal. So when a child comes in with those kinds of rapid symptoms, in addition to having an MRI scan that shows a tumor that fills the pons, that appears to encircle the basilar artery, and I'm going to show you what that means in a moment, that it appears to stop at what's called the medullary junction, the bottom part of the brainstem, and it has some very characteristic appearances on MRI scan. It usually doesn't enhance when they inject gadolinium partway through, and it's usually bright on the signals that measure water. That's the definition of a classic DIPG. It's important to know, though, that not every tumor in this area, in fact, is a DIPG. There are some very subtle characteristics. Any tumor that starts a little bit above or just a little bit below the pons usually has an excellent prognosis. And in fact, it's those patients that often account for the long-term survivors in many of the studies where they're not paying attention to the exact criteria for both the clinical and MRI appearance. And so what you should see in front of you now are two slides. On the right-hand side is a patient, is a normal person. And again, on the left-hand side is the picture of the tumor. On the right-hand side, where you can see now, that's what the area should look like. And as you can see, this is the pons right here. And you can see that in this patient, it's quite swollen. You'll notice that it almost looks like the tumor stops right here at this boundary. That's, again, that appearance of obeying the medullary boundary that's classic in these tumors. Tumors that go below that area are often not real DIPG. The other thing is, so these are the water signals that I talked about, and this is a normal patient that, again, has the artery that feeds the brain up where my arrow is. And here you can see it almost looks like that area has now moved into the middle of the brain. And those are kind of critical, again, in being classic for DIPG compared to the normal. And then this, again, is just the same thing. So again, this large tumor that fills the pons, as well as obeys that boundary, that has the involvement of the basilar artery. This is a patient that almost for sure has classic DIPG, and those are the ones that we're going to focus on today. Now, the treatment of all tumors, no matter where they occur in the body, usually relies on three different treatment options. The first is surgical resection. And since, as I said, this is the part of the brain that determines when you breathe and when your heart beats and your blood pressure, by definition, a surgeon cannot go in and just cut this area out to remove the tumor, because to do so would remove the functions of the brain that are critical for life. It doesn't mean we can't biopsy per se, and we're going to talk about that momentarily. So because surgery has never been a major component of the disease, and because the diagnosis is based on the MRI scan and the clinical symptoms, once the decision is made that this is most consistent with the DIPG, the patient goes to radiation therapy. Now, we're going to talk a little bit about chemotherapy in a moment, but unfortunately, that conversation is going to focus on why chemotherapy doesn't work. In fact, as of today, there is no chemotherapy that's been proven effective for children with DIPG. So not surprisingly, the focus is really on radiation therapy. It's typically given over 30 to 33 days, 5 days a week, so normally about 6 weeks. And basically, you just radiate the pons in the surrounding area. And if you do that, you change the aggressiveness of the tumor. So instead of causing death in about 4 weeks, instead the average child dies at about 9 months. So there's no question that radiation has a major impact on the improvement of the outcome of these children. What's also important is many of the kids, the symptoms that they were diagnosed with, at least for the first many months, all go away before they come back and get started again. Some people ask a lot of questions about what about protons versus photons. They're no more effective one than the other, so there's no advantage to protons. The standard treatment is photon therapy for these kids, and it's pretty well the same all around the world. So this is called a Kaplan-Meier curve, and this is basically how we measure the success of a treatment. And obviously, the goal is to keep the line flat at the very top, not at the bottom. So the 1.00 that you see at the top is the survival of kids having been treated with DIPG. And at the beginning of treatment, not surprisingly, everyone is still surviving. But you can see very quickly here there is a decrease as the patients start to succumb to their DIPG. And in fact, you'll notice that at about the 50% mark, which means at a time when half of the kids have already passed away and the other half are still alive, is around 8 or 9 months of time. So again, not very long. The dotted line is a clinical trial called ACNS 0126. It was a national trial that we ran around the United States, parts of Europe, North America, throughout North America and Australia. And basically it was radiation therapy plus temozolomide. And as you can see, the kids did not do particularly well, and we therefore no longer use temozolomide as standard alone therapy for DIPG. The second curve that you can see is this CCG 9941. That was radiation with different types of chemotherapy. And you'll notice that although initially it doesn't seem to do any better, there were 3 long-term survivors in this study. And of course the question is, did those 3 kids have a different disease? Were they the low-grade gliomas, or were they actually DIPG? And of course there's no way to answer that question because the tumors are never biopsied. You can't know exactly what they are, and so you can't know why those 3 kids survived and the other 100 that got exactly the same treatment did not. But it certainly suggests that this is not a very effective therapy for the vast majority of children. So with regards to the chemotherapy, this is an approach that unfortunately was unsuccessful for pretty obvious reasons in hindsight. So the assumption, remembering that we don't biopsy these tumors, so we don't really know anything about them, is we assume that they must be very similar to adult high-grade gliomas or malignant gliomas of the upper part of the brain, because adults don't really get DIPG. And the assumption was that we would use the therapies that the adults were working on in the hopes that under those circumstances we could hit a bullseye. And unfortunately, that was somewhat unlikely, but we hoped even if we could just kind of get close to the target, at least we could start improving the survival a little bit until we finally found out how to hit the bullseye more accurately. Unfortunately, what's really happened is that the darts have not even come close, and now having thrown some 250 of them, we haven't come close to the bullseye yet, and the reasons for that are going to become evident in a couple of minutes. So when you say, what have we done over the last 30 or 40 years for kids with DIPG? So we know the radiation makes a transient improvement, but is not enough to cure the tumors. So we tried giving kids pre-radiation chemotherapy, post-radiation chemotherapy, pre- and post-radiation chemotherapy, immunotherapy, biologic therapy, radiation sensitizers, anti-angiogenic therapy, gene therapy. If you can name it, we've tried it. And unfortunately, every single one of those trials was unsuccessful. We have really now done everything but the kitchen sink. And I think it's reasonable to presume that if we could get a kitchen sink in a syringe, we would certainly have tried it. We tried everything else. And the unfortunate thing is that in hindsight, every one of these kids still died of their tumor with no benefit. But it's not just that they didn't get benefit. Actually, they were worse off because they actually got all of the toxicity of all of those different drugs and no benefit whatsoever. We certainly made them sicker. We didn't make them better. And in that sense, we didn't do them a service. And the real question is, we were so busy trying not to biopsy these kids to put any risk of the biopsy there. In some ways, we gave the kids a different risk, ineffective therapy. Now, unfortunately, the discussion with families, and this is a discussion that really has not changed in the last 50 years, is again, we make the diagnosis based on the clinical history in the MRI. Because biopsy is considered unethical, we tell you we're not going to learn anything about your child's tumor. And so we basically always say 4 basic things in every conversation with every family. And I suspect somewhere in North America today, a number of families were sat down to hear this conversation. The first is, we're always sorry about what we have to tell you, that there's always hope, but realistically there's not much because the number of known survivors of DIPG is incredibly small, that we'll do everything at least to make your child comfortable. And again, we're really sorry. And that's a conversation I have had now literally hundreds of times with families over the last 20 years, again, because we have made no progress in this disease. And so the real question was, could we consider biopsy so that we would actually know something, so that we could actually do something intelligent? And so the concept was, could we change the very way we think about these tumors? And that's not trivial, but if you could biopsy these tumors, not only could you learn about what starts them, what drives them, if there are differences between them, each child could get the treatment that works best for them. We could finally learn what actually triggers these tumors, and in so develop the right therapies, remembering that it's not just important to have a drug that will kill the target that you're going after. It has to penetrate into the brain through this thing called the blood-brain barrier so that we can actually effectively treat the tumors. And that turns out to be much more difficult than we think. In fact, if you ask how many of those 250 clinical trials did the drug being tested not even penetrate the brain, it accounts, in fact, for the majority of those trials. Well, if your child has a DIPG and you're using a drug that doesn't penetrate the brain, those drugs really had very little chance of being successful anyways. So the other thing that I think is important to say, that when we propose doing a biopsy to learn about your child's tumor and how to better treat it, doesn't mean that you're saying that a child has to have the biopsy or that the family has to agree. The question is, for families who want a biopsy, should they at least have the right to do so? Because if you pick up any pediatric oncology textbook, in bold letters, in every single case, it always says the same thing. It is unethical to biopsy a child with a brainstem tumor. And when that kind of dogma was decided on 30 years ago, that actually made a lot of sense. The neurosurgery wasn't particularly well advanced, and so you did a lot of damage without a lot of benefit. But the argument was that the progress in the neurosurgical techniques and in the ability to analyze these small pieces of tumors have so advanced in the last 30 years that maybe it was time to question that dogma. So back in March of 2002, Mike Prados, a pediatric oncologist at UCSF, and I had been lamenting the fact that we were making no progress, and we couldn't just keep having that same conversation with families about there's no hope and we're just sorry. And so we raised the proposal nationally that we begin to biopsy these protocols. And I have to say that the response was overwhelmingly negative. Everyone reminded us that in every textbook the dogma is clear: you do not biopsy these tumors. Have we not read any of the books? And the answer was, yeah, we've read them. We're just not sure that they're as up-to-date as they need to be. So anyways, in 2003, we made the same proposal, and unfortunately didn't go well. So in 2004, we did the same, and in 2005, and in 2006, and in 2007, and in 2008. And we certainly deserve some credit for being relatively stubborn and not giving up. And then finally, in 2009, something really important happened that I think changed the entire landscape for both children and families with DIPG, and that was the French. So they have a slightly different system of medicine there. And finally, the group in Paris at the Necker Hospital for Children in downtown Paris finally said, actually, we're just going to biopsy about 20 kids and see what happens. And they biopsied them, and lo and behold, all of the children tolerated the therapy well. They proved that they could do the biopsies and they could actually learn something from them. At which point now in North America, we were somewhat stuck in a little bit of a quagmire. We either had to agree that the French neurosurgeons were infinitely better than North American neurosurgeons, or it was time that we finally got on to the recognition that we can safely biopsy these patients. And so, although started in, or proposed in 2002, the trial for the biopsy of children with newly diagnosed DIPG and their treatment based on the results of that biopsy finally got approved in 2009. So a 7-year delay, and unfortunately a lot of kids who therefore I don't think got the right therapy. And these are the centers that are taking part in the trial, so it's throughout North America at major centers here at Dana-Farber and Boston Children's, in Boston, at UCSF, at Chicago, Los Angeles, Johns Hopkins, et cetera, major institutions. One of the things we did is we tightly regulated the way they would be done to ensure that it would be safe for the children. So you could only take a certain number of very tiny biopsies, about 1 millimeter thick, to make sure that it would be okay, that we have all kinds of independent people looking over every single thing that we do to make sure that no child was hurt, injured, or was inappropriate. We used drugs that we knew could penetrate the brain and were safe. Every single time a child is treated, we speak with the team. I have a telephone call with the team to make sure that everything is going okay. We have all kinds of FDA regulations called INDs and IDEs to make sure that the FDA had complete control. We had these mandatory stopping rules, so we treated the first patient, and then we weren't allowed to treat anyone for almost the next year, and then we treated the next patient. We had to wait a little bit, so forth and so on, to be absolutely sure that it would be safe. So we certainly took the safety part very seriously. We didn't want to hurt these kids if it wasn't going to end up helping them in the long run. The other thing we did that was a little bit controversial at the time is we actually mandated that all of the neurosurgeons who were going to take part in the biopsy protocol go through some specialized training to be sure they knew how to do it. Just being a certified neurosurgeon would not be enough. And the training for the neurosurgeons was run by one of my colleagues at UCSF, Dr. Nalan Gupta. And so again, to ensure as much safety as was possible. And this is a picture of a child getting ready to undergo the biopsy. So you can see just the small area where they're going to go in. And so actually the actual hole is quite tiny. And then this is actually the MRI. And you can actually see from these yellow lines exactly where the needle is going to go in so that we know exactly where the biopsy comes from in the tumor as we try to understand exactly what the tumor is all about. And then normally the kids can go home in a day or so after the procedure, and again, they have tolerated it quite well. So the good news is now, having done 50 children around the United States, we now know that biopsy is safe. Again, it doesn't mean that just because it's safe in a highly controlled and trained circumstance that anybody ought to do it, but at least with the appropriate controls, it is safe. I'm going to show you in a moment that one of the first things we discovered is DIPG is completely different from all of the adult brain tumors on which we had been basing all of our 250 clinical trials, which probably explains why they didn't work. In fact, it turned out that the DIPGs are different even from the same looking tumor in other parts of the brains of children, suggesting that the location in the pons is particularly unique. And then the other exciting part of this was we actually identified a number of mutations, all of which may be possible therapy options for kids with this disease. Now, at the same time we were doing the biopsies, we and others were also starting to look at autopsy material, not so much because that in any way can help one of the children that's already passed away, but again, because it does provide us some more material on which we can start cell lines, for example. We can start growing some of the tumors in dishes and then treat them to see if we can kill the cells. So instead of having to do all of this in kids, we can actually do it in either dishes or mice in order to allow us to find the optimal therapy before we actually start to treat the kids. So having done that now, I can tell you that there are now multiple cell lines and multiple models where that's exactly what we're doing. We can grow the cells either in culture or mice, and then through treatment, see whether the mutations we're identifying are actually going to make a difference in terms of treatment. And the slide you see in front of you now is what's called a neurosphere culture from the cells of a patient with DIPG, where you can grow the cells up into these clusters, into these clones, and then begin to test them with different drugs and see how many of them you can kill off as a measure of efficacy. This is an animal model of basically the same thing, where you can grow the tumors in the pons and then you can treat them. In this particular example, these animals down here got treated with radiation therapy, just like we give kids, and then they either got no treatment or a new therapy for a type of molecule called CDK4/6, and based on that, what you see here, these are the animals that got just radiation therapy. These are the animals that got the drug. You can see it didn't cure any of them, but what it's starting to do now is make them survive longer. And obviously the question now, will that work in kids? And those are the kinds of things that are now being tested. In addition to those mice that I showed you, these are examples of zebrafish, where we can again put in the same mutant genes and then ask whether drugs can make them better. This is an example of mice with, again, the pontine tumors grown in them, and you can see at the very top, these are animals that didn't get any effective therapy, and you can see that over time, the tumors keep getting bigger, brighter, larger. Here's an animal that got a drug called MK1775. It doesn't do a great job. Here are animals that got irradiated. It certainly slows them down before they start to grow. But when you combine the two together, what you now see is you're starting to actually cure some of those animals. And again, the question now is, can you do that in human beings? This is an example of a mouse brain where they can spontaneously start to grow the animals. Again, since obviously in kids, no one injected a tumor into the brain, we need to find out whether we can start them spontaneously and then see how to stop them. And this is an example from the Stanford group of doing exactly that. We can also take some of those samples and analyze them under the microscope for certain molecules and see whether they have them or not. This is for a molecule called ACVR1 that we're going to talk about in a moment, where you can see much of the tumor is positive for it, but we can ask which cells are actually positive and how that controls the tumor. The other thing we've been able to do is take some of the cells and analyze their chromosomes to begin to ask questions: what parts of the chromosome are abnormal, and are there any specific mutations that might account for the start or the cause of DIPG? And so this is an example of one of those analyses. This is from the Toronto group based on autopsy cases. Again, autopsy cases are a little bit tough because that means the patients have already received all of their radiation and stuff, which changes the tumor. So this probably doesn't represent what the tumor started as, but it's still, again, it still gives us some important information. Here you can see these are the chromosome 1, chromosome 2, chromosome 3, so forth. So in the arrow here, this is chromosome 14. All of the blue bar means that in patients with DIPG, chromosome 14 is usually deleted. When the same tumors keep deleting the same gene, it often raises the question that there must be something on that chromosome that makes a tumor not want to grow, and that's why they get rid of it. You'll notice that compared to the DIPG, if you look at high-grade gliomas, that same area of chromosome, in spite of the fact that the tumors look exactly the same, when you see the same area from a tumor that arises in the upper part of the brain, not in the pons, you can now see that those same abnormalities aren't there, and that therefore gives us some ideas of where to look at critical regions that may explain why you have DIPG. This is another example from Dr. Baker's group. This time we're comparing DIPG to low-grade gliomas, so patients, virtually all of whom survived their tumors. It's very rare to ever die of a low-grade glioma, and you can see a couple of things. The first is, if you look at this patient, so each column is a patient with a DIPG, and again, each row here is chromosome 1, 2, 3, 4, just like I showed you before. Again, if you compare this patient's DIPG to this patient's DIPG, where the red means they've amplified parts of their chromosome, the blue is where they've deleted parts of their chromosome, you can see that this patient's DIPG seems to have very little to do with this patient's DIPG, suggesting that not only are they different from low-grade gliomas, they're actually often different from each other, which means one treatment may not be appropriate for everyone. Now again, these were from autopsy cases, so whether that's relevant to newly diagnosed cases is a little bit hard to say. The last thing we discovered about the mutations of the chromosomes is this one thing called histone mutations. And for any parent that's done any reading on histone mutations will know that this has really been one of the major discoveries in the last 3 years, and it has to do with these things called H3 mutations that are highly identified in patients with DIPG, as I'm going to show you in the vast majority of cases. So the obvious question is, well, what are histones? Well, if you go back to some of your high school biology, remember that you have the chromosomes, the DNA, that basically has the blueprint for how to make a human being. And obviously, remember, we all started out as a fertilized egg, that at some point, that one fertilized cell has to become 2 cells, and then 4, and then 8 as we get bigger and bigger. And then at some point, it's got to start making a liver, a heart, a kidney, a brain, et cetera, and the way you do that is in the blueprint of all of your chromosomes. There are certain areas that tell your heart how to be made, how to make your liver, how to make your kidney, how to make your brain, when to divide. Remember that a dividing cell, which is obviously bad for a tumor, is normal at the beginning of your life because by definition, if you stayed just a single fertilized egg, if you didn't divide and start to proliferate, you could never become a full adult. And so division is normal in the early parts of development, and then as you get older, once your heart is finished forming, you stop the proliferation so that it doesn't get too big. The same with your liver, the same with your kidney, and the same with your brain. And the way you turn things on and off is with these parts called histones that basically are these large structures that basically turn off, keep areas in the off position. And what happens in DIPG, in those H3 mutations I just showed you, is these little red things. These are called little tails, and there's one single nucleotide abnormality that puts a mutation right where my arrow is kind of showing in these different histones that allows some of them to open up. And the reason that's important at this position 27 is that when the normal amino acid here gets converted from a K to an M, that single mutation allows whole parts of your genes, your chromosomes, that should be in the off position to get turned back on. And some of those tell parts of your brain, including this area of the pons, where the mutation occurred, that it's okay to start dividing again. And the problem is once you start dividing, you end up with DIPG. So this is an example of the brain and spine, and this is the H3, the histone mutation. So here is the classic mutation right here for children with DIPG. It's called the H3.1 mutation, and it's associated with this thing called ACVR. We'll talk about that in a moment. Sometimes kids with pontine tumors, instead of having this mutation, have, for example, what's called the H3.3 mutation, but you'll notice that this bottom mutation, while the upper one you don't see in any other part of the brain anywhere, the bottom one you can actually see sometimes in a part of the brain called the thalamus or in the spinal cord. So sometimes the mutations can occur in other places. In this mutation called the H3.3G34 mutation, only occurs in kids with tumors in this upper part of the brain. It never occurs in the pons. And what that tells us is that although the histone mutations are important, different histone mutations appear to drive different tumors in different locations, and that appears to determine what kind of tumor your child is going to have. So one of the things we were able to do in addition to the histone mutations is in working with the French group, they actually sent us 20 of those cases that I had told you they had first biopsied. And when we analyzed them, one of the first things we discovered is there's a mutation in a gene called PIK3CA, PI3 kinase, and that's important because actually a number of pharmaceutical companies have started developing drugs against that mutation. So knowing that about 1/3 of all kids with DIPG have that mutation suddenly means we have an opportunity to maybe start treating those kids. Obviously, if your tumor doesn't have that mutation, then that inhibitor wouldn't be right for your child. So this is an analysis of tumors, and every single column here, so there are hundreds of patient samples on this. Each column is a different child. Each row is a different gene. And what you see here is the pink are DIPGs, and the yellow are basically the same looking tumor, but in the upper part of the brain. And what you can see here is in this area right here, these are genes that are overactive, and in blue are genes that are underactive. And you can see that DIPG has this pattern of the genes that are overactive and underactive are different from the same looking tumor in the upper part of the brain. Again, it tells us that pediatric DIPG is different from other high-grade tumors in kids. So the treatments that would work for these kids, again, are not relevant necessarily for these kids. What was more important is when the same group in Paris looked at those kids, so again, each column is a child with newly diagnosed DIPG, not only were the DIPGs different from other tumors in other parts of the brain, they're actually often different from each other. So these kids have these down genes, whereas other kids with DIPG, exactly the same tumor in exactly the same place, those genes are up, and vice versa for other sets of genes, suggesting that there are at least 2 major types of DIPG, and that therefore there are at least going to need to be at least 2 different therapies, maybe more. So this is a somewhat complicated slide. The only thing I wanted to show you here is these are the DIPG samples, and these are the Same looking tumors, but from the upper part of the brain. And as we start to put this much bigger puzzle, as we put all of this data from all of the groups together, what we begin to discover is that you see these things called PI3 kinase pathways, both in the midline tumors and in the cortical tumors, but the types of abnormalities you see are different. The same for these things called the growth factor receptors. So, for example, in the pink ones here are those PI3 kinase, or the ACVR1 mutations that I talked about that you only find in the kids with these central tumors, never in the ones in the upper part of the brain. And then similarly, you can find things like ATRX, which are equally divided in both types, but you virtually never find them in kids with the ACVR1 mutation. And so we're beginning to see a pattern where the different types of DIPG line up. If you've got one type, by definition, you don't have the other. And you can kind of see that here. So for example, if we talk about ACVR1, you can see that if you have ACVR1, you are always the H1, the 3.1 histone mutation, and you almost always have the PIK3CA mutation as well. So this is a patient, if you were going to treat this tumor with an ACVR1 drug, you would also treat it with a PI3 kinase drug, where if instead you have the PDGFRA mutation, you can see that none of those things are associated. Those drugs are not going to be as relevant. And understanding those different combinations are going to help us determine the optimal therapy for each child at diagnosis, as seen here. So I've talked a little bit about this thing called ACVR1, only known to occur in kids with DIPG, and about 30% of them. But one of the interesting things about this mutation is that it's found much more frequently in girls than in boys. And obviously the question is, why is that? We don't know the answer yet, but it's important. It will be important to figure out why, in particular because if you take all of the tumors that are ACVR1 mutated, those kids tend to survive many months longer than the kids that don't have it, the gray line that I'm pointing out here. And that's going to be important because if you're trying to find out how well a therapy is working, if we know that the average survival for a child with DIPG is 9 months, like I told you before, and you give a new therapy, and now suddenly it's 12 months or 13 months, you would say, aha, we've increased it by 4 months with this new treatment. But if it turns out all you've done is had a whole bunch of girls with the ACVR1 mutation, it's not that your drug worked well at all. It's simply that those are the kids that are going to survive a little longer. And understanding those differences and what causes them is an area that we in multiple groups are now trying to study. So what is this thing called ACVR1? Well, as I've said, it was never known to be associated with any cancer until we biopsied these children. In fact, this is what the gene looks like, and these are the abnormalities that are actually occur in the kids with DIPG. And the reason that's important is that there is one other disease where these same abnormalities have been identified, but interestingly, having nothing to do with cancer, it has to do with this disease called fibrodysplasia ossificans progressiva. And this is basically a disease where as you get older, in addition to your normal bones, which are made of bones, all of the rest of your muscle and skin and fat also start turning to bone. So some people, the disease is referred to as stone man's disease because you're slowly turning to stone. And eventually, obviously, because your lungs can't breathe and your heart can't breathe, eventually this becomes fatal and patients end up dying. It's interesting, they never die of tumors, they die of this fibrodysplasia. So the question one would ask is, why is this strange mutation that causes this terrible disease also the same mutation that causes DIPG in about 1/3 of all cases? And obviously we are working kind of frantically to try and figure that out. One of the important things is the people that have this disease, they started to develop a drug against it, and we're now asking the questions, would that same drug work in kids with DIPG? We're hoping the answer to that will be yes. Those are some of the tests we're just starting to do in those animal models I talked about before. So what have we talked about so far? We've discovered these histone mutations, and we have some drugs that we're now testing against them. We discovered PI3 kinase mutations. We have some drugs we're testing against them. We identified the PDGFR mutations. We have drugs that we're testing against them. We have the ACVR1 mutations. We now have drugs that we're testing against them. Remember that up until 2009, we knew nothing about this disease because it was based just on MRI scan. In just these 6 short years, we have really made leaps and bounds in terms of our understanding of this disease because we started to biopsy, and fortunately biopsied safely. So the last thing I wanted to do is, we said that this was going to be kind of the new direction, and you've heard a lot of the exciting things that we're just beginning to do as we develop better therapies for this tumor. But it's not just understanding the mutations. I talked about before, example, how do we actually get the drugs that go into the brain? So some of the drugs that I just told you about, although they're very effective at attacking the molecules that are abnormal, we know they don't get into the brain very well. So one of the recent discoveries has been this finding that there are certain veins in your nose that actually pass right by the pons. And so actually what some people are now doing is taking some of these drugs and actually squirting them with this special spray into the very upper back part of your nose so that we can actually get some of the drugs to the area of the pons right here as a way of more effectively treating them. Other groups are working on these things called interarterial administration, where you take the drugs and using these catheters, you hopefully can see this little black line that goes right into the artery that feeds the pons. You can deliver all of the drug directly to the place where the tumor is. And this is an example of what's called convection-enhanced delivery. So this yellow line that you see is where you've put a catheter into the pons, just as if you were going to do a biopsy, except instead of taking a biopsy out, you leave the catheter in, and then you hook the top of it up to the drug that you want, and under very high pressure you push it into the brain, into the pons, and you can see here it spreads all around the area where the tumor is as a way of actually trying to kill the tumor. That's a way of getting a drug in that normally wouldn't go in all on its own. And so there's an opportunity that's become critically important in terms of effectively treating these tumors. So I'm going to stop there. Again, DIPG, we've learned, is different from other tumors. It can be safely biopsied, but should be done so by an experienced team that's part of a national protocol. We've now discovered multiple mutations, which means there isn't going to be a single treatment for DIPG. The best treatment for your child is going to depend on understanding some of these mutations. But now that we've got the mutations in the animal models, we're finally beginning to understand exactly what those abnormalities are. So I'm going to stop there. I know it's now over because we lost some of that initial time. I'm happy to take some calls or some questions if the organizers still think there's time.
Thank you, Dr. Kieran, for the very interesting presentation on DIPG. We have reached 2 o'clock, but I think we have a little bit of time that we can use to take a few questions. So if you have a question you'd like to ask, please type and submit it using the question box in the webinar control panel on the right-hand side of your screen. All right, I have one question here. We'll start with this for Dr. Kieran. Number one is, what is being done to address the recurrence of DIPG? And are there any clinical trials specifically addressing recurrence?
So the problem, of course, with a recurrent trial is, so there are some recurrent trials. They're what are called, so they fall into 2 types. The first is some people are retesting whether you can re-radiate the tumor to try and slow it down again, since the radiation worked the first time. And in some patients, they get a lot of toxicity from the radiation. In other patients, it actually does stop their tumor for a couple of months. So it does give them a couple more months before the tumor starts growing out of control and no longer responsive to radiation. So that's one of the things that people are doing at recurrence. The other thing that people are doing is they're taking some of these new experimental drugs and actually testing them in patients that have already received their upfront therapy, whether it's just radiation or not, to see whether or not any of these drugs might be working in your particular tumor or not. Those are typically experimental trials, so it tends to be done at the bigger centers with experimental therapy programs. Whether or not any of those drugs will work, of course, will depend on how much is known about your child's tumor, what mutations are present, and what drug is being tested.
All right, thank you. We have another question on how effective are after-death MRIs and biopsies in adding effective additional data to the pool of research material.
Yeah, it's obviously a very tough issue to have to ask a family, given everything that they've been through, when their child comes close to passing away, that would they consider a biopsy, or would they consider us at least to do a partial autopsy to get some of the tumor and try to better understand, given that there's much more material there than we could ever take with the upfront biopsies. I have to say that some of the critical mutations that were discovered from autopsy cases, and so part of the advance that we now have is because some families consented to do this. Obviously, a family should never feel obliged to do it, but the one thing that many of the families that have said yes to it have come back and said to me is, listen, we understand our child is dying or is going to die. If there's anything that we can do that would help another family in the future from going through this, we would be willing to do that. We know that it's too late for our child. And if it's appropriate for you in those circumstances, that although it doesn't help your own child, it does help, it can help others, then it's worthwhile. Here at the Dana-Farber, for example, we'll pay the cost for the funeral home to take them to the local medical center to have the brain and spine removed, and then the child goes right back, so it doesn't delay the funeral or any of those things. But then they can send us the material, we'll pay for all of that, so that all of that stuff can happen without losing an unfortunate opportunity. Again, it's important though for people to realize you've been through enough. If it's not right for you or your family, you're not at all obliged. You shouldn't feel obliged. But if you think it might be the right thing and that the opportunity to continue to learn from your child's sample, we're desperate for some of those samples. Hello?
Sorry, can you hear me?
I can hear you.
I have another question here that's related to whether there's any evidence that DIPG is inherited or linked to a hereditary mutation.
Yep, so that's a great question. Obviously, every family, once they find out their child has a cancer of any time, is worried about what are the risks to my other children and so forth. As far as we know, based on the mutations that we have found so far, none of them are what are called genetic syndromes, the kinds of things that are passed down in families. And part of that probably has to do with the fact that most of the genetic diseases in which you pass something down means that you have to have survived. It has to be a disease where you can survive the disease long enough to have your own children to pass it on. So, you know, the breast cancer gene, for example, since most people don't get breast cancer until they're 30 or 40, means that they have the time to have a child before the gene causes cancer. In DIPG, which really is almost unheard of in adults, it's really a pediatric disease, because the kids don't typically survive into adulthood, means that there's no chance to pass it on, and there really has been no recognition of any genetic syndrome that's associated with that. So the good news is none of your other kids are thought to be at any risk for this disease, nor are their kids.
All right, we probably have time for 2 more questions. The next one is are there any results on studies about CBD and THC molecules?
That's a great question, and it's obviously a kind of hot area right now. So there are a couple of studies that are now going on, not just for DIPG, but for multiple tumors, to look to see if there is any activity for any of the cannabinoids to see whether or not they actually have anti-tumor activity. By definition, we know they get, at least some of them get into the brain, because that's where they have their very effect that's made them somewhat popular. The issue is that it's relatively new data and people are just now starting to study it, both in animals and in human beings. And so it's not an area where we have the results yet, but I expect we will have results in the next year or two.
Also, regarding therapy, can you discuss the recent success of the BRAF mutation in targeted therapy?
Yes, so the BRAF mutation is a common mutation in malignant tumor, in both the low-grade tumors that have a very good cure rate, but also in pediatric patients. This is not true in adults, but in pediatric patients, about 10% of the high-grade, the malignant tumors of the upper part of the brain have what's called the BRAF mutation in them. And surprisingly, this new inhibitor of BRAF has turned out to have potent activity in many of those patients. Unfortunately for DIPG, not a single case of DIPG has ever been found to have the BRAF mutation. So although it's going to be an important treatment, it already is for the tumors in the upper part of the brain, it's not going to be relevant for patients with DIPG. You could look at it the other way, though, and say, listen, if there was a mutation in the upper parts of the tumor for which they now have a drug that's having these dramatic results, then having found mutations in the DIPG, our hope is that we will be able to get the same success, not with the BRAF drug, but at least using the same concept. With one of the mutations we found in DIPG, we should also be able to find an effective drug at some point for these tumors, and that's exactly the studies that are going on now, both in animals and in patients.
All right, thank you again, Dr. Kieran. I think that concludes our question and answer session, and that's all the time we have for today, but thank you all for joining us, and thanks again Dr. Kieran for this wonderful webinar presentation on DIPG. For more information on brain tumors to help patients and caregivers process the diagnosis, understand a new and difficult vocabulary, and access resources to help make informed decisions, please call the ABTA Care Line at 1-800-886-2282. Now we'll pause for just a moment to conclude our webinar recording.